So the major cause of kidney disease is eventually inevitable kidney failure, dialysis talaga.
Unsa man ang percentage nga maingon nato nga dili na naga-function ang kidney or kinahanglan na mag-dialysis ang isa ka patient? Did you know that one of the things that we really considered before we opened a dialysis center was we really wanted to be able to serve the needs of the community, and we are so happy that we are in the business of helping people. That is why today I invited two important people to discuss about chronic kidney disease, and they are here to be able to inform us and inspire us about this disease and what we can do about it. So let me introduce to you our very own medical director, Dr. Vida Rose Danielle Acosta. Hi, Doc.
Hi, good morning.
Okay, so si Doc Vida Rose, she is our medical director sa NephroMed, and she is a practicing nephrologist at MDMRC, Metro Davao Research.
Metro Davao Medical and Research
Metro
Center.
Davao Medical and Research
Center.
Center. And she's also working in their family hospital sa Tibungco Doctors Hospital. So, let's all welcome Dr. Vida Rose. Doc, mangutana lang ko, what is CKD, chronic kidney disease? Is it synonymous with kidney failure?
Yeah. Chronic kidney disease is medically defined as abnormality in the structure and function of the kidney. So, ano ba yung function ng kidney? Mainly to clear the body of waste products, to filter out the blood, excrete the waste products. And another function of the main function of the kidney is to maintain a proper volume. So, kung may excess fluid, the kidneys excrete that out, the excess fluid, so that proper volume of the body is maintained. So, if there's an abnormality in the structure, not only grossly, but sa microscopic level, and also eventually sa function ng kidney, we define that as chronic kidney disease if it persists for 3 months, more than 3 months. No? So, chronic kidney failure, yeah, it is somehow synonymous, although it may sound very parang heavy, no? Yung failure na word. But in a sense, it is true because of the dysfunction of the kidney. So, the kidneys fail. And if it's chronic kidney disease, it happens gradually. No, the kidneys fail gradually. So, the major cause of kidney disease is diabetes. It's a worldwide problem. And that's the number one cause. And the second cause is hypertension. But they usually go together. So, once a patient is diagnosed with diabetes, she most likely will be diagnosed with hypertension. And eventually, when the kidney disease progresses, even if the patient is not hypertensive at the onset, he or she can be hypertensive because of the renal problem. Because BP is also regulated by the kidneys. No? So, a third cause is what we call glomerular disease, glomerulonephritis. It is kanang hubag sa kidney, inflammation sa sulod sa filters, sa glomerulus sa kidney. And that starts, most often, it starts at a younger age. Bata pa, nag-ihi na og dugo or naay dugo sa urinalysis. Although, dili siya makita grossly na blood, but upon urinalysis, microscopically, may dugo. And may protein, nagabula ang ihi. And then sa urinalysis, may plus yung protein. So, those are some indications already that the patient has glomerular disease. Or bata pa, naghupong na. Hupong ang tiil, no? So, ganun. Another cause of kidney disease is obstruction. Kung may stone, nagbara sa daanan ng ihi, sa ureter, or sa bladder outlet. Let's say prostate, kasi the prostate is located sa ilalom sa bladder. So kung may enlargement ng prostate, especially sa elderly male population, the pressure goes back in the kidneys and that causes changes doon. Other causes, frequent use of painkillers. I will not mention the brands, but we call them NSAIDs, non-steroidal anti-inflammatory drug. So if they use that frequently, daily or halos every week, because they have arthritis or they have headaches or any body pains, frequent use will also lead to kidney failure. Even uric acid, if it's always high at a younger age, nag-start na mataas ang uric niya, we also have that uric acid nephropathy. Recurrent UTI, it also causes kidney failure. Multiple cysts sa kidney, when it's a genetic problem, adult polycystic kidney disease, napuno na ng cyst yung kidney, so it has replaced the normal 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 na unod sa kidney, nahimo ng cystanan, eventually inevitable kidney failure, dialysis talaga. So those are the more common causes, although there are some other causes like congenital problem, nung pinanganak sila, isa lang yung kidney, hindi nag-rotate to its normal location, nasa ilalim, lumiit siya, no? So, or while buntis si mommy, may nainom siya na gamot that caused the failure of the kidney to grow, no? So, yeah. But the major cause talaga is diabetes and hypertension, and yung mention ko na glomerular disease.
So these are the top three?
The top three, yeah.
Doc, mangutana lang ko, kaning madungog nato nga, pila na lang ka percentage, 50% na lang, 20% na lang ang naga-function sa kidney. How do they compute that percentage? And unsa man ang percentage nga maingon nato nga dili na naga-function ang kidney or kinahanglan na mag-dialysis ang isa ka patient or chronic kidney disease na siya?
Yeah. We compute for the kidney function based on the EGFR, estimated glomerular filtration rate. And there's a formula for that, although we use a calculator because it's complicated, no? The normal EGFR is at least 90 ml per minute per meter cube, no? So the basis for computing the EGFR is the age of the patient, the gender of the patient, the creatinine especially, and kung Black American or not Black American. So it depends, no? So those 4 parameters, no? If the creatinine clearance or the EGFR is 90 and above, that's considered normal. In the book, we define chronic kidney disease as an EGFR of less than 60. So there's the EGFR between 60 to 90, even if it's not considered CKD in the book, we also refer to that as stage 1 and stage 2 already, no? So because part of the definition of CKD is structural abnormality. So we see patients, even if their creatinine clearance is still above 60, but there is already structural, microscopically, there is structural damage already. Even if the EGFR is not less than 60, we still classify them as stage 1 or stage 2 CKD. So when you say hindi na nagpa-function, we refer to the stages, no? 1, 2, 3, 4, and 5, no? So we do dialysis when the EGFR is less than 15 or at the stage 5 of CKD already. So kung stage 3, EGFR of less than 60 but more than 30. Stage 4 is EGFR of less than 30 but more than 15. But if the EGFR is less than 15, that's already stage 5 CKD. But at the 5th stage of CKD, it doesn't mean automatically we do dialysis, no? There's a study comparing early and late initiation of dialysis, even at the CKD 5 na. And it showed no significant difference even if you start them late na. Pero inevitably, if the EGFR is less than 8, less than 10, those patients already complain of uremic symptoms kanang unsa man ang symptoms of toxicity because of the chorea. So luya, nakaayo sila, nagasuka, dili na mukaon, maamoy nila ang food, luod ilahang paminaw pirmi, nagahupong na because wala na tong function sa kidney na volume, no? I-excrete yung extra fluid, no? Hindi na masyado umiihi yung kidney. Paminsan may tremors na, uremic tremors, hindi makatulog, yun, no? Or nangangati, pruritus, uremic pruritus. So usually lumalabas yan sa CKD stage 5, no? So if at the CKD stage 5 na sila pero wala pa silang overt na symptoms, dili pud mi automatic na mag-dialysis, no? Sometimes we wait, no, na may konting symptoms, pero if lumabas na yon, then we really push for dialysis. But when the patient reaches stage 4, we prepare, no? We prepare na for dialysis, but we don't automatically start it. So at stage 4 pa lang na CKD, we advise, ma'am, sir, we explain, no, the options for renal replacement therapy. So we could have peritoneal dialysis, we could have hemodialysis, and we could have kidney transplantation. So yun yung 3 forms of renal replacement therapy. If the patient opts for hemodialysis, we advise them magpahimo na tag fistula. Fistula is it's an artery and a vein na nilagyan ng connection, kinonect sila to create pressure, no? That will be the access for dialysis. So, and because this cannot be used immediately after surgery, it has to be done earlier. Kasi pag dumating ang time na may symptoms na siya, may uremic symptoms na siya, ready na ang access. And we don't have to insert a catheter sa leeg because yung catheter sa leeg, it's for emergency dialysis. So, yun, for us to start dialysis, the patient has to be at the stage 5 of CK. If this is CKD we're talking about, there's another type, yung AKI, acute kidney injury. So, dialysis may be started. It depends on the status of the patient. Pero kung CKD, yung sinabi ko, gradual, progressive loss of function of the kidney, we start it at the stage 5 of CKD when the patient develops symptoms already of uremia.
Okay. So, Doc Vida, since you mentioned about peritoneal, hemodialysis, and kidney transplant, asa diri sa tulo ang pinaka-best nga treatment?
Yeah. So, among the 3 that you mentioned, the best really is kidney transplantation because the normal function of the kidneys are back. No? Previously, when the patient was on dialysis or peritoneal dialysis, his hemoglobin is low because there's no production of the hormone that pushes the bone marrow to produce blood. He has to do dialysis so that the extra fluid can be removed. No? He takes medicines to control his blood pressure. So when a new kidney is put in the patient through transplantation, all the malfunction complications because of the dysfunction of the kidney, it reverses. No? Although these patients still maintain on some medications and importantly immunosuppressive meds, but the normal functions of the kidney are back. So the patient urinates normally. And the hemoglobin is up even if he doesn't inject yung erythropoietin, balik na sa normal na processes. No? But it's crucial na mag-take yun siya og tambal para dili ma-reject ang new kidney because it is foreign to him. So naturally, ang body niya will recognize that as foreign. The body will produce something to attack it, kay foreign body ang consideration. So that's why muinom siya og tambal to lower his immune system para dili siya mag-produce og antibodies to attack it. Pero when the kidney transplantation is successful, gwapo ihi niya, creatinine is back to normal, wala na siya symptoms of uremia, he will not require dialysis anymore. He doesn't have to go to the center. He doesn't have to infuse peritoneal fluid para mag-dialysis siya. So maganda yung quality of life. It's just that he has to maintain medications to prevent rejection.
So for life yung maintenance ng immunosuppressive medications.
Yeah,
Now the next question, Doc, is kapag ka nag-kidney transplant na ang isang patient, for life na ba siya nga dili na mag-dialysis, normal na siya or naagyapoy chance na magbalik siya og dialysis?
Yeah. If he's maintained on medications, he properly takes them, he doesn't miss his dose, and he has his regular checkup, the kidney is functioning well, his life may be extended for several years, maybe 20 years or more. But eventually, we know that as we age, there is also a corresponding decrease in the eGFR of the kidney because it's a natural process. Kita tanan, ang atong kidneys mo age. So, ang gihatag na kidney saya, mo age pud to siya, no? It's an inevitable. So, eventually, mo hinay-hinay pud og decrease ang function ana, no? Especially, masamutan og decrease ang function kung nag-stop siya inom sa tambal, nag-miss siya dose for whatever reason, nagpabaya sa diet, so diabetic siya at the start, so na-control ang sugar niya previously and then nag-akala niya pag na-transplant na, okay na kumain ng madami, no? Salty food and high sugar food. So, ang diabetes niya, up again, high blood, up again, eventually, ma-damage din yung kidney. So, all those factors that could cause an insult to the kidney before, when he was not yet transplanted, he was not on dialysis, naulit na naman, na-expose na naman siya to those factors, so affected na naman yung, yung bagong kidney. So, he may be back to dialysis if the new kidney fails, no, because of those reasons, or nag-reject siya because kulang yung gamot niya. Kasi after transplantation, you really have to follow up with your doctor, your nephrologist, your surgeon, para ma-maintain yung level ng gamot. We usually do a drug level monitoring. So if the dose is not enough, we adjust up, no, depending on the classification ng patient. So kung hindi niya na-maintain yung drug level niya, mababa or sumobra din, nag-toxicity siya because of the medicine, no? So affected din si kidney. So even if he already underwent transplantation pero nagkaroon ng dysfunction uli doon for whatever reason, he will be back to dialysis. Yeah.
Okay. So, Doc, since you mentioned katong mga causes sa kidney disease and also kaning mga things that can make it worse, no, or magka-complicate if ever mag-kidney transplant ta. Unsa man ang imong ma-advise sa mga patients na naay chronic kidney disease? Unsa di ay dapat ang ilahang food intake? Unsa ang ilang mga bawal pod, mga food restrictions nila?
Yeah. So any person diagnosed with chronic kidney disease has to limit, number 1, his salt intake. In the guidelines, it has to be less than 2 grams of salt a day, or parang ganito lang, kalaki, sa thumb natin, dito lang. But it's kind of difficult to measure because especially if you're cooking for the whole family, isud man i-measure niya para sa isa ka patient lang, no. So what I usually advise is just salt to taste. So kung magluto lang, sakto lang na salt because we also need salt sa diet, no. Dili ta pwede mag no salt, no, mag low atong sodium pod, magluya ang tao. So salt to taste, no. Kung may need na palamion pa ang food, we add other seasoning, not really seasoning, kanang
Herbs?
Yung mga pepper, black pepper, you can add that para lang may lasa. Spices, but it doesn't have to be salt, no? And yung mga toyo or what.
No toyo, or pwede?
Well, for me, personally, okay lang, konti lang para magkalasa lang, no? Pero not excessive, wala na isawsawan. No?
Okay.
Enough lang na maluto ang food. Tapos, yung mga chichirya, bawal yan siya. Canned goods always have sodium to preserve it, diba? So we totally advise against eating canned goods, no? Protein is also essential sa CKD, no? If the patient is not yet on dialysis, we restrict the protein because creatinine actually comes from protein, from meat. No? So, ang allowed lang ng guidelines for protein is palm size lang or strictly matchbox size per meal. Yung palm size is the whole day, yan siya, na meat. And we prefer fish over pork or over beef, no? Or sige, occasionally you can have chicken, pero ideally fish sana. But careful din sa fish kasi may mga fish na mataas din sa uric, like mga tamban, mga ganun. Tangigi also has high uric. Yung ginagamit sa sardines, yung mga mackerel, those have high uric. Actually, even tuna, meron din yan siyang uric.
Tuna and salmon?
Yeah, meron din. So we usually advise yung white meat na fish, no? Lapu-lapu, mga mahal. Lapu-lapu, mga isda sa bato, no? So, yun. And kung hindi masyado umiihi na yung patient because nga may hupong siya, chronic kidney disease, dili kayo siya makaregulate sa fluid sa body, even if gusto natin sa CKD, sige inom tubig, no? Pero kung restricted ta because nagahupong ang patient, we limit the fluid intake, no? That is for mga CKD-han na nagahupong na. Yun, sa uric, we control. Salty because tataas din ang BP, no? If you take salt. Kung diabetic ang patient, low glucose, low sugar diet na siya. Also, avoid, yung sinabi ko earlier, avoid anything that would further cause injury sa kidney, like yung mga painkillers. No? If your creatinine is already high, you avoid those painkillers na pangit sa kidney. So, we only use paracetamol. Safe siya. And kung severe ang pain, we can use tramadol, no? If talagang in pain yung patient. Yung other kinds of NSAIDs, bawal na. Herbal meds, in na yan siya ngayon, no? Ang dami nating mga herbal meds, no? We nephrologists really would not advocate, no, herbal meds because these have no backup studies, no clinical trials to prove their effect, no, no toxicity profile. So actually sa box ng herbal meds nakasulat no approved therapeutic claim. So it's up to you if you take it or not. You have to take the risk if you take it, no, kasi nga no approved therapeutic claim siya. So all meds kasi should undergo clinical trial, no? And it has to be scrutinized kung meron siyang toxicity sa organs, no? So kung merong ma-prove na ganun yung mga medications na yun, sige. But if wala, parang pinalabas lang na organic, natural ito, and then walang backup study. So those might cause, no, we term that as tubulointerstitial disease sa kidney, no? Unknowingly, nag-take ang patient, hinihinay dahil nagasaka yung kriya and he or she doesn't know. No? So, yun. Basically, yun.
Thank you so much, Doc. I really learned a lot, and I'm sure whoever is listening to us right now or watching this video really learned a lot from you.